So I want to move forward with our next roundtable discussion, which will focus on perspectives on health IT in Indian country. This roundtable will explore various ways tribes have engaged in health IT modernizations, including lessons learned and the unique tribal needs that a modernized ITU inclusive health IT system must meet. So I am joined today by Rosario Arreola Pros, who is the Chief Operations Officer for the CRIB, California Rural Indian Health Board. Also Melissa Gower, Senior Advisor Policy Analyst for the Chickasaw Nation Department of Health, she's joined by Renee Fondren, who is the Chief Information Officer for the Chickasaw Department of Health as well. Also welcome Sean Schweitzer, who is Help Desk Specialist and Boots on the Ground for the Great Plains Tribal Chairman's Health Board, and Rhonda Beaver, who is the Chief Administrative Officer for the Muskogee Cree Nation Department of Health. Welcome to all of you, and thank you for joining us today to share your amazing insight and perspective on health IT modernization. So to start our discussion, we'd like to have each of our panelists introduce themselves and briefly share with us your tribe's experience with health IT modernization, including some of the challenges and lessons learned along the way. So can we start with you, Rosario?
Yes, good afternoon, everyone. I'm Rosario Arreola Pro, the Chief Operations Officer for the California Rural Indian Health Board. We are an association of tribal health programs with 19 tribal health programs and 59 tribes throughout the state of California. California Rural Indian Health Board has been deeply involved with EHR, electronic health records, and particularly with supporting commercial off-the-shelf EHRs amongst our membership and our 638 contracted members particularly. In terms of our work, we have a long track record. Of course, there's been many more organizations that have continued to provide and engage in that support to tribal health programs. And I'm here to share a little bit more about that today. Thank you.
Thank you. Melissa? Can't hear you.
Sorry. Okay, I'm Melissa Gower. I'm the Senior Advisor Policy Analyst for the Chickasaw Nation Department of Health. I'm joined today by Renee, who's going to introduce herself in a minute, but we're going to share a little bit about, I'm going to share some information about my attempts and efforts to being involved in the HIT Modernization project nationally, and then just a little bit about...
Okay.
Sorry, I don't know what happened, but I actually didn't do it that time. And then, a little bit about Chickasaw Nation's journey on our HIT modernization. Thank you.
Thank you.
I'm Renee Fondren. I'm the IT Director for Health and Family Services with the Chickasaw Nation.
Thank you, Renee. Sean?
It doesn't look like Sean is on right now.
Okay. All right. Well, then we'll go with Rhonda Beaver. Is she there? Okay. Well, again,
hello, everybody. Sorry, I'm having some computer.
Okay. Thank you.
What
Rhonda.
a time! Hi, what a time to be having computer challenges when you're talking about HIT, right? But me and Zoom are not friends, for the record. But hi, my name is Rhonda Beaver, and I've invited Brandy Cunningham, who is our IT director, and she will be on shortly. But we're going to talk about some of our experiences, and we are actually in the process of implementing our 6th EHR. So we've got some experience, and boy, do we have some stories to tell. If we had the amount of time to let you know everything that we went through, I just don't know if we could have a conference of our own. But I just want to thank you for thinking of us and having us here today. and Brandy will be on shortly, and I'm sure we'll have more to add. So I look forward to the discussion. Thank you, guys.
Okay, great. Well, let's go back around then, Rosario, and we'll ask that each of you, what advice or priorities would you share with other tribes as we move forward with the health IT modernization effort?
Well, in terms of advice, I think one of the biggest considerations that's always on the top of our minds here at the consortium here at CRIB is costs. And there's a lot of bells and whistles, a lot of layers that you can, a lot of great add-ons for this great emerging technology that we have. But the costs are also quite substantial. And so being realistic about prioritizing what is really most important to your program and not just grabbing onto whatever the latest and greatest is, because that may, unfortunately, if you put too much money towards some of these newer efforts, you may not be able to really make the most out of some of those other more foundational elements. So I know that even during this COVID pandemic, you know, telehealth really took off, and we are so excited that it finally had a grasp, especially in Indian country. I think that was really key in our rural communities. But working with your vendors and identifying vendors that are beyond just your what comes with your packet of your EHR packet is going to be really key, because you actually now as a consumer then have options in terms of what you can add on. And so I think keeping that in mind, that there's a lot of great stuff coming out, but there's also, you have to prioritize and also be smart about where you spend your dollars.
Okay, great. Melissa, you got some insight?
So good afternoon. I'm going to talk a little bit about efforts at the national level, about monitoring our efforts in monitoring and our involvement today with the IHS EHR modernization project. Probably a few years back, we decided at the Chickasaw Nation that we wanted to look at all of the options available to us. And it was around the same time, or actually probably a little before, IHS started looking at their options. One of the first things I wanted to do was to become involved in the IHS ISAC, which is the Information Systems Advisory Committee. So I finally got on the email list and started participating in those meetings. And I first just want to, talking about advice, if you're interested in HIE modernization, you really should start participating in those calls, whether you're on the ISAC or not. I know that in my participation, there's been issues with having quorums. We get really good updates. There's open discussion times where anyone can ask any question about anything. I just looked this morning, and out of the 12 tribal representative, 12 area tribal representatives, 7 of those are currently vacant, which is very concerning, I believe, in our participation and interest in HIE modernization at the national level, which is going to affect each and every one of us. So my first piece of advice is please get involved in the IHS ISAC meetings. And if your area does not have a representative, put forth a representative, and let's get some better, good all around 12 area tribal representatives on that committee. The IHS modernization project through the process has done a lot of things to gain tribal input through site visits. I think we were one of the sites that they visited. There's been tribal interviews. There's a tribal consultation on the statement of objectives that was in last June, several rounds of that. And I just say, every chance I get, I try to talk to IHS about communicating to tribes and communicating ongoing and soon about this project so that everyone feels like that we're at the table and we have a voice. I have been told that there will be a Dear Tribal Leader letter coming out soon. That's going to solicit the tribal representation. And this goes back to some slides AC Locklear shared about the tribal representation on some of the committees. So I look forward to that. The other thing I wanted to mention is funding. You know, funding it's a very interesting, but I think it's a somewhat divisive subject in my opinion. And that's really because, you know, everyone, all tribes are at varying states of HIE modernization, really between moving completely to a CODIS system, a partial use of some CODIS systems, as well as RPMS, to spending their time and resources on maintaining RPMS. And also where we are is in evaluating the options available from completely RPMS and IHS operated sites. And then so you can see that it is a very complex process to determine really a fair and equitable funding distribution for everyone. I know that IHS has identified $3 billion over 10 years. And one of the questions I had asked IHS is, what does that $3 billion represent? And it does represent just an estimate based on total patient population compared to the VA funding, which would include all patient populations. So that would include tribes as well as IHS direct sites. And so the Chickasaw Nation in specific, we do continue to utilize RPMS, and we have invested a lot of resources, both human and financial, in development of RPMS applications and maintaining the system. We have somewhat what I would consider outgrown the system. And so that has prompted us to begin exploring all of our options to meet our healthcare IT needs. Thank you.
Thank you, Melissa. Renee, did you want to add to that?
The only advice that I would stress people take is invest the time now. Know your processes, know not only what your EHR is touching, but know what pieces of registration they may have hidden in a drawer. So when something goes down, you don't see an obsolete scanner coming online. Health IT modernization truly is global. It's not just about picking the EHR. I believe it has to be a true and genuine partnership with each department. Not that we need to be the SMEs for clinical, but we really need to know how to provide the support so that patient care does not suffer. It's important to keep those documents updated regularly. It's important to work with the departments when they're looking to purchase something, that you as your IT team understand how that future support will occur. IT always likes to be the service provider who can do it all. But the fact of the matter is our resources are seriously limited. And so it's not fair to our departments to purchase something and then them not be able to fully utilize it the way they expected. So I just recommend building that strong relationship, having your IT department get out from behind our four walls and actually get to see some of the patients, get to work with the departments and understand what their needs are as you start evaluating those processes to implement an EHR.
Thank you. I understand maybe Sean has joined us. Is that correct? Okay, if you are joining it, oh.
Yes.
Okay, well, let's move on then to Rhonda and Brenda to see same question, advice or priorities you share as we move forward with health IT modernization.
You know, I'm going to agree with everything Melissa said in terms of I think it's important to be involved, because as we look at this HIT modernization roadmap that IHS has put out, I think as a tribal entity, it's important that we get involved because I really think we have a lot to say. I think that, you know, we've got stories to tell. With us being on our 6th EHR experience, I think, you know, there's a lot of lessons learned that we could share with IHS, but I also think it's important as they develop the governance structure that tribes have input on that governance structure. And as they talk about funding and equitable distribution, I think that's very important for the tribes because we know that moving forward, EHR is going to be one of your highest operating costs as you move forward. So I think being in the discussions to talk about this funding distribution and how it's going to affect these tribes, and just a little bit of background about our experience or who we are at Muskogee Nation is prior to 2006, we were already using an off-the-shelf program to bill out. We are a unique tribe in that we see natives and non-natives and our hospitals. And so we needed to find a system that would effectively capture the data and capture what we needed in terms of billing because we were doing fee-for-service billing. So we needed to make sure that we had the system. So the question is, what are some of the lessons learned? I think it's very important to sit down and put pen to paper exactly what you're looking for in an EHR. What do you need? Just as if you're getting ready to plan a Christmas trip or plan a trip, where do you want to end up? Because there's all kinds of vehicles to get you there. You know, you can get a Pinto, you can get a Cadillac, you can get a Chevrolet, but really, what do we need to get to our destination point? And I think as a tribal entity, you need to sit down and kind of put pen to paper and figure out exactly what do you need. Do you need third-party software? Do you have labs? Do you have pharmacy? Are you seeing non-natives? What type of data are you trying to capture at the end of the day? Do you need it for business analytics? And so I think it's important that you sit down and you start identifying some of your needs today. And then you start developing a roadmap, how you're going to get there. Which systems do you want to look at that even have some of these? Because I think what we found out is there's so many business suites out there, and we've tried a lot of them, and we've tried to put 2 and 2 together to make sure that these business pieces fit together, and they didn't. And so what we had to do, for instance, we have Cerner and we have NextGen for the clinics, is we're trying to get these 2 systems to talk to each other. And so at the end of the day, we end up choosing Epic. And so that's who we are in the process of implementing right now is Epic, because it had every piece of the puzzle that we needed as a tribal health system. And that will vary from tribe to tribe. So I think it's important to just sit down, get a game plan. Where are you trying to go? What are you trying to do? And how are you going to get there? And Brandy may have some more technical components to that. So Brandy?
Sure. Good afternoon, everyone. Along with, and I agree, cannot say it any better than what the ladies before me have said, and definitely Muskogee Nation's road down the EHR path. But one thing that you have to keep in mind whenever you're how and when and where and how we're going to make this happen is
Brandy,
so we all know that infrastructure is optimal. So that's okay. That's one thing as an organization that we have spent a lot of time building out and improving our network backbone, our redundancy. Every site is redundant now through 2 separate carriers. We are working on moving to a disaster recovery site, so we have a hot backup if something happens. You know, we all know that here in Oklahoma, we live in Tornado Alley, and we don't want that data center going down because it's going to be vitally important if we have a natural disaster to be able to provide community support and support for our patients that we serve. So not only that, but we've also had to make sure that just our PCs and our laptops are up to date. And with Epic, there's a lot of technology, a lot of interfacing, a lot of telemetry systems. barcode readers, you name it, it touches it. So that was a lot of investment and time that we've put into that to ensure that we can meet the needs of our patients, and we can use Epic to the fullest.
Okay.
It looks like there is a question I can answer about the EHRs and IHS and GIPRA measures.
Okay.
So actually, yes. So we currently have a bidirectional interface with IHS NDW for COVID reporting. Those are reported every day at the end of the day. I think they go in around midnight every day. And we are currently working to have a real-time interface for NDW and GIPRA when we go live. So we will be reporting those monthly, similar to what is happening now out of the RPMS systems.
Okay, there's another question in the chat. What did the financial investment look like for implementing Epic in your clinic? And did IHS provide any financial or IT assistance with this implementation?
Rhonda, do you want to take that one, or do you want me to?
Well, I'm thinking we may have a non-disclosure agreement in terms of how much the cost of it, but it's in the millions. We can say that, and I can also say that no, we have not received any funding other than we have in our budget line for IT already. But in terms of implementation costs and interfacing costs, we haven't received any additional dollars for modernizing our IT.
And so another question, there is another question I have the chat up, and it's asking, did we purchase Willow and Wisdom? Actually, we did. We are going Epic. We have all of their separate packages. So everything's moving to Epic, which is going to be nice for us because right now we're a best of breed. So we have several different softwares that we are using that we've put together over the years to meet our needs. And we are actually really excited to be going to that one record across the health system. And of course, it's less to maintain too.
Do we have any other questions?
I have a question in general. One of the areas, of course, there's one of the concerns is in having a system that it can be integrated with all these different platforms, and hopefully even be, of course, vendor agnostic. I know that in terms of the cost, some things to also consider are, who you can perhaps interface with, or with the ability to ramp that up rather quickly. One thing that we have been dealing with in California is that we don't necessarily have ready access to electronic case reporting at this time for communicable diseases, and that became even more so apparent during the pandemic. So just thinking about how your system, whatever system you choose, allows you to then engage with systems even outside of Indian Health Service and tribal or urban clinics, because really we're in a day and age where you need to be able to have that level of communication, but being able to build those, I guess, work on those partnerships along the way as you're building this infrastructure is going to be also really key, so that you're not left outside of those spaces.
Right. And for Epic, that is one of a really key component to Epic. They actually do have that integration. So through some of their software and their different things, they do have the ability to connect electronically to non-Epic partners to share data. And we are actually in the process of doing that. And it makes it easier to share data across Epic partners. So those folks have access in and to certain records, and they can request records electronically, and our patients can through MyChart and at point of care. So it makes the transition to care much smoother and much more ready available across the United States. And even if you're traveling outside of the United States, it's available there too.
Okay, we had some questions about interfaces, one with PRC, unique Indian Health Services programs. How does Epic interface with that? And then also with pharmacy, commercial off the shelves like Script Pro. Anyone want to answer that? Either of those?
So yes, so PRC, we have developed an in-house PRC software that is interfacing with Epic. It does allow us to process our contract health referrals in real time. And as far as does Epic interface with other pharmacy cost systems like ScriptPro? So yes, they do. But I will tell you, unlike NextGen or Cerner or some of the other third-party systems that are out there, you will have to have your own interface agent. So there is no Rosetta, there's nothing like that. So we have contracted that piece and it is working very well. But that is another thing of, I think that you need to be conscious of when you're moving through this process of who, what, when, and where, and how. Interfacing with Epic is a very, very big piece. And you're either going to have the folks on your staff, hire those folks, or contract that out. So, and Michelle, you'd asked about Care Everywhere. Yes, that's what we're speaking of, is Care Everywhere with Epic. And then it says, do most COTS include APIs? I can tell you that with Epic and NextGen and Cerner, we use APIs in HL7 to integrate.
So we have another question. How large is the organization that is using Epic? We're told that they don't fit for smaller hospitals. Would you like to share a database with another organization?
Well, I think that kind of depends. I think that if you're a very small organization with maybe 1 or 2 clinics, they do want you to become an Epic Connect partner with a larger organization. And as far as the smaller hospitals, I think that's probably on a case-by-case basis, probably in a conversation with them on what they're willing, how small they're willing to go. I really can't, I can't speak to that. And I don't know, Rhonda, if there were any discussions maybe that I had not been a part of, I'm not really sure. But I think it totally is case by case.
Another question on whether they're cloud-based.
We are Epic hosted. You have the choice of being Epic hosted or hosting yourself.
I have a question, and this relates to Brandy. I know that you have experience working with a variety of systems. For your current Epic location, did they replace an existing COTS or an RPMS system? What was their legacy system?
We are replacing existing COTS. So we are getting rid of NextGen and Cerner and going full Epic across the board. And we are only keeping 2 legacy systems. We are keeping SciImage as our PAC system, and we are keeping McKesson for our outpatient pharmacy and our high volume solution mail order pharmacy. Otherwise, everything is going to Epic.
Okay. Are there any other questions for our panel?
This is not a question, but it is a comment that Brandy and I talked about on some of the lessons learned for the Muskogee Creek Nation. Is if you are thinking about doing a modernization for your EHR, we would recommend doing a master patient index first. We think had we had a master patient index first, it would have made the transition so much smoother because we would have owned all of that data and we could have just moved it from whichever system we wanted to use. However, without the master patient index, we've had to figure out how do we transition this data from one system to the next. So I think if anybody's looking forward to moving forward, that would probably first and foremost is to develop an infrastructure in the master patient index.
Yes, absolutely.
Okay, and before we move on to the other questions, I do understand that Sean is on and he represents direct service tribes and within the Great Plains area. Does anyone have any questions for Sean? Or Sean, would you like to maybe make some comments about your experiences and some of the issues that you've had?
Yeah, I work for the Great Plains Tribal Children's Health Board right now. Before, I literally just came from a direct service unit in Eagle Butte where it was IHS.
Do we have any questions for Sean as far as his experiences? Okay, well then let's move on to, let's see, another question we have is what type of info is included in the master patient index? And then another question on, let's see, if I can pull this up. Well, we'll start with that one.
So for Muskogee Nation's Master Patient Index, we are including a holistic approach for our patients. We are including all medical records, inpatient, outpatient, dental diagnosis, demographics, tribal information, contract health information, and payer information. So it makes it much easier to go in and mine that data and get a full look of our patients across the health system as a whole. You can really choose, if you're building your own, you can really choose what's important to you. And I know that this has been, I don't know if a labor of love is the right term or not, but I know that this has been a huge priority for us as an organization. And it is coming to fruition, and we do have one, and we will continue to build on that as we grow. We'll continue to add different elements as needed.
So we had a question on what parts of the country are using Epic versus Cerner versus others. And the comment that from Ed Fox that it would make sense to choose Epic where dominant and Cerner where it is. So do we have a sense for that?
I know in Eastern Oklahoma, well, actually for most of Oklahoma, it's for the third-party system, the large systems, the Ardent, the Ascensions, the Mercy, they are Epic. And I don't know if you would want to choose based on what's dominant in your area. I think it's best to choose on what's best for your organization and what meets your needs.
Okay.
I think it's also important to note that once you get knee deep or neck deep in EHR system, that data governance is also going to be important moving forward, and it'll also be important in this HIT modernization because we implemented in 2009 a full EHR system, and now that we have all of this data at our fingertips, what do we do with it and how do we protect it? We've had some companies that wanted to come in and actually try to buy some of our data so that they too could sell it off, but I think it's important that we cling to that and we protect it, and we have a responsibility to do that. So once you get so far into an EHR system, you're going to have all of this data at your fingertips, and then you're going to want to know, I guess, have a plan on how are you going to use this data and who are you going to allow to have access to this data. So that will become a hot topic or a major issue down the road and something to keep on the back burner. Thank you.
Kind of related to that is a question from Robert that asking if there are any issues with data ownership, because that's one of the critical things that tribes are concerned with.
I'm not sure if I quite understand the question. I know that we own our data. Epic does not own our data. It is hosted, but of course there's agreements in place for that data. So I'm not really sure what the question is about that mostly for smaller tribes, tribal 638s.
I think it's important to make sure that you have strong and deliberate language in your contracts and your agreements whenever you engage with third-party vendors or you engage with EHR systems. I think it's important that you have deliberate language where it states that the tribe owns the data and that you know what's going to happen with data, because there are some situations where maybe they don't have access or they don't use names, but they may use aggregate data. So I think it's important that we're very cognizant of that whenever we sign or enter into any agreements.
A related question, do tribes own our data or does IHS own our data? Anyone have a comment on that?
And I think that's the type of discussions that we need to be having in these ISACs meetings moving forward as we talk about governance structure. Those are the type of questions that we need to have, because, you know, IHS can share some of our data with CDC or some NIH or any other organizations. So I think those are the type of questions that we should be having. I think that's what Melissa was touching on earlier.
Okay, AC, we have some hands being raised. I think Steve Coots has his hand raised. Can you open that up?
Yes, I was just going to comment on a couple things because I'm in the middle of all of this right now myself. So what happens is if you buy a Community Connect version, you're buying it from a hospital system or bigger system, and they're the ones that say they're going to own the data because you're paying them to get access to their system of Epic or whatever it is that you're trying to get a hold of. If you go directly to the manufacturer of that, if they have it on the cloud, they're not going to probably let you take it off, but they're not going to do anything with the data. What I've been trying to talk to tribes doing, and when I talked to Stacy about having this is to try and get tribes in a certain area together, or even across the country, whether it's Greenway, whether it's Epic, whatever it is, to allow them to have a user group for tribes so that you can try and figure out what the best enhancements are that you want, and then you all can figure out how to pay for it. Because otherwise, if you just or them, you'll pay them to do an enhancement, and they'll sell it to everybody else for something that you just paid for. So trying to get these different entities to agree to have a user group, and I would suggest maybe we try and get a user group across the United States for all of them. If you do that, and maybe we form our own user group, even if they don't agree to have one. And it's almost like we get together and try and encourage them to do the things that we want them to do, because you have some power in numbers where when you're by yourself you don't. So those are just a couple of thoughts that I had. But when if you go to a Community Connect version of whatever you have, you're only getting access to whatever system they have in place. And you cannot hardly convince them to make any changes to their system unless it's going to be effective for their broader system, and they've thought that that's going to be helpful to do that. So just a couple thoughts. Thanks.
Okay, thanks, Steve. So Joe made a comment that perhaps it could be in the contract language what the tribe and what to do with it if they move to another platform. And that seems like it's good advice. Any other questions?
I have a question, and this would be for all of those who are considering moving from one COTS to a different one. Like, how they say, if it ain't broke, don't fix it. So I'm wondering, what are your biggest considerations that help move you to actually take that leap to leave the one COTS to then go to another?
Rhonda and Brandy, that would be a good question for you, since you said you moved through 6.
I think for us, it was growth. Whenever we engaged into NextGen, we were primarily clinics. And then whenever we acquired a hospital who was using CPSI at that time, we had to have a hospital system that could accommodate. And so I think ours has just been a lot of growth. And I think that's probably been the driver for most of our changes. Brandy, do you have anything to add?
I agree with that. And in one system, while we are growing extensively with services and locations, we really needed one system. And Epic is going to provide that for us, and that consistency of care across our entire health system, where we're not having to log into one or log into the other or go in and print this out or try to interface and keep those interfaces going. So growth, yes. If we were still the size that we were in 2009, I think NextGen would be fine, but it just simply isn't.
Anyone else want to add on what triggered moving from one to a COTS system?
Epic, by the way, does not have a travel user group. I asked their representative from Minnesota or wherever they come from. They do not have a travel user group. So I would suggest that if people go with Epic, try to get that.
So they do not. NextGen does. I know that there's a few folks on here that's probably been involved in that, and NextGen has a very extensive, robust tribal users group across the United States. Epic, Rhonda, are we with their first actual tribal customer? I think that they've written some things in for different folks in different areas, but I was thinking we're their first full on.
I believe so, Brandy. I believe so, but I know that they're very interested, and I think we're having to do a lot of education to Epic, which is always a problem whenever you use a off-the-shelf product, is we're having to educate them. And so that's what we're in the process of doing right now. But I think once we get everything tailored, they're more, and they understand that some of the health systems out there are standalone health systems and that they may not be as huge as an Ascension. So I think they're trying to open up that market for any other tribal health systems. They also had indicated that if we wanted to, as Muskogee Nation moves forward, that we could possibly host some of these smaller tribes on our system if we wanted to do that. And that's something we're looking at doing. We hadn't got that far yet, but it is a possibility if maybe a bigger tribe in the area wanted to get involved with Epic, then they could host some of the smaller tribes that are at the state, within the state.
Would it cross states, you think, or would it just be within the state?
Brandy, you want to answer that?
Sure. I mean, there is the ability to cross states with technology the way it is. We are a hosted system in Epic. So we would have the ability to create connections, all the way across the United States. You would have to get into different particulars about different things about support and what type of support and how much support if you're going to go across states and training and things like that. But I think tribes hosting tribes is a lot easier than kind of what Cerner has now with their community works. And Epic has come a long way in the last year and a half with understanding tribal health and really getting to know us and those unique needs that we have. So, but yes, you could do it anywhere.
Okay, so let's see. We have a question. So if IHS does go the way of Cerner, won't they be offering hosting?
This is Steve Kutz. Could I throw in something while you're thinking, Carolyn?
Sure.
So when Epic came to Washington State and all of the tribes met with them, virtually none of us were big enough to go to them singly. It would have taken almost all of us to get together to deal with Epic directly, because they're a big system type of organization. So that's why a bigger tribe that is big enough has the capacity to host other tribes. But there is another version of Epic out there that people can go through, and it's hosted by a company, a nonprofit organization in Oregon called OCHIN, OCHIN. Did you mention that, Carolyn?
Yeah, if you wouldn't mind sharing, Steve.
Yeah,
my role moderator, right. I think I can share some stuff.
So they have about 600 organizations across the United States currently that are there, that are with them, and they're starting to offer that to tribes. They predominantly have federally qualified health centers, family planning clinics, public health departments, and those type of agencies. But now they're starting to offer it to tribes, and you get a full version of Epic, and they have about 20 add-on packages that they sell. And I'm in the process right now of trying to figure out how they do their costing. So for example, if you want to contract with them to do your billing, they want 5.5% of your revenues, and 0.5 if they do the I guess if they keep track of it for you and don't just bill. And I told them when I was talking to him, I said, you're building that on an FQHC model, because typically a federally qualified health center reimbursement rate, because they're predominantly on Medicaid, is a whole lot less than ours. And I said, tribes would have to be overpaying. You would be overbilling us if you charged us 5.5 or 6% to do billing for tribes. But they have pharmacy packages, they have dental packages, they have a whole slew of add-on things that they add on to Epic, if you want to look at that. And the piece that they have is you have to have a minimum of 5,000 billable visits a year in order to enter into a contract with them for their system. So I suppose if
Steve, you dropped off.
What I said, you have to have 5,000 billable visits. So if you were a tribe that had less than 5,000 provider billable visits in a year, you could probably join together in a consortia and do something. But they're probably worth taking a look at if you're trying to deal. And so in our state, we're having conversations with our state about buying that system for the tribes in our state, so in Washington State. So we're in conversations with that, and we're about 96% certain that it's going to happen next year.
Okay, great. And then we see that that Ed Fox shared the link for the OCHIN. So the question is, so they are charging 5.5% for billing and coding.
That was for if they did the billing. what they charge for that, I don't really know. And if anybody on here's with Ocean and you've got that figured out, I'd be interested to know. But that's if they were going to do billing for them. Coding was, I think, 0.5%, and billing was 5.5%, and coding was 0.5%. But if any of you have figured it out, I'm in the process of doing the application, and I don't know if they sign you to confidentiality agreements or whatever they do. They weren't able, they want to talk to you individually. So maybe get together. If everybody was trying to get together at once, I'd have a conversation with them together, but that doesn't seem to never happen.
Yeah, and I think, you know, the non-disclosure issue has been our biggest barrier to trying to quantify what the cost is. So I really appreciate Stuart sharing some of his information this morning. Seems like there should be a transparency discussion moving forward, similar to what the conversation is with hospitals and disclosing their charging system. Just a thought. So we did have a person ask about if anyone was using the Greenway Energy and if they would be willing to share best practices and workflows offline. So if anyone is using that, if you wouldn't mind responding in the chat or directly. Okay, we have about 5 more minutes for any other questions, or I would offer, if there are no other questions, offer any closing remarks from our panelists, please. Okay, well, let's go ahead and start with any additional closing remarks, Rosario.
Just want to thank all of you for your insight and sharing what is ahead of us. I think that for many of us, we've been doing this for 10, 15 years, even longer. And there is an opportunity to rethink what we're doing. So definitely, I appreciate everyone's thoughtfulness and sharing, where you're at today and keeping in mind where we want to be tomorrow. So lots ahead, and looking forward to continuing these types of conversations. Thank you all.
Thank you, Rosario. Melissa, any final? You're on mute if you're trying to speak. Renee, I'd offer the same to you.
Okay, thank you. It was very good to have the conversation. I appreciate hearing where everyone is. I do hope that there becomes a tribal census to where we can focus together and really move this initiative forward.
Thank you, Renee. Sean, do you have any comments? Okay, and we'll move on to Rhonda or Brandy.
I think I'm going to surrender my time to Brandy, but I just want to tell everybody thank you so much for the conversation.
All right, great.
Sure. So I just think it's important that we can continue to collaborate as tribal health as we move forward. And I think the modernization is very important. It's very important to our organization. It provides better healthcare. It allows us to provide better healthcare for our patients. We are really, really excited where we are as an organization moving forward with Epic. But we're also excited to see how IHS also moves forward during this modernization project.
Great, and definitely want to be part of the conversation. So again, I'd like to thank all of our panelists on both of these roundtable sessions for your excellent insights into these important issues. And I thank you for the feedback from the group in the chat for for your comments. So if anyone has any additional questions that they did not get to share, or if you think of later, you can please drop your questions into the chat or send them directly to AC again at alocklear@nhb.org, and he will make sure we get those answered. So at this time, I think we can move into our breakout sessions, and I'd welcome AC to come online to provide instructions on the next step. This will be our last session, next to the last session before we come back as a group to do a recap and report out. PC?
Thank you, Carolyn. We'll now go into our breakout sessions. These